Dr. Namrata Sharma. She don't need any introduction to this August gathering. The honorary secretary and the multifaceted personality of All India Ophthalmic Society.
Thank you.
Over to you, Dr. Namrata.
Kind words. I think this is a very important topic today on endophthalmitis, and I will be talking to you about intracameral antibiotics for postoperative endophthalmitis, more so from the results of the study that we have done on almost 16,000 patients now. So I think all this must have been already talked about, and so I will not go through this again. Intracameral antibiotic prophylaxis has already been studied. Various drugs have been studied like cephalosporins, vancomycin, moxifloxacin. ESCRS study which did strongly support the use of intracameral cefuroxime, but it is not available. And vancomycin, which used to be used earlier, does cause hemorrhagic occlusive vasculitis, and so it is not used. Moxifloxacin is one drug which is used, and I think it is now available in injectable forms from two companies with no financial interest in any of them. One is the Cipla and the other is Alcon. The bactericidal levels are maintained for longer duration at clinically administered dose following intracameral injection of moxifloxacin, and this is well proven by Arshinov. And in vitro comparative models have also been studied. And this is the published literature, and I think there's huge amount of literature which is there which says that moxifloxacin is safe and it is effective and it can be used for intracameral prophylaxis. Now, this study was retrospective, although it looked at 9 lakh eyes, and the results favored intracameral antibiotics at the end of cataract surgery, with no difference in the efficacy between intracameral and topical antibiotics versus intracameral antibiotics alone. And this was yet another study which looked at cataract surgery over 1 lakh eyes with no IC prophylaxis, over 1 lakh eyes with prophylaxis. But important thing to note in all these studies is that these are retrospective studies and there are no prospective studies. I know of ESCRS who was wanting to do this kind of a study with 75,000 patients, which was planned as a multicentric trial but did not happen because it was very expensive to do it in such studies are expensive to do in US and in Europe both. So we did a randomized control study, and there were some gaps also in the study because of the COVID. But this is a prospective evaluation of intracameral moxifloxacin for prevention of post-cataract surgery endophthalmitis. And the study was started before COVID, so we calculated the sample size of our center, and we also included Sadhguru Netra Chikitsalaya Chitrakoot to get that huge sample size, because otherwise it is very difficult to get a huge sample size. And so in group 1, phacoemulsification was done, followed by intracameral injection of moxifloxacin 500 microgram per 0.1 ml, and in group 2 routine phacoemulsification was done with no intracameral antibiotic alone. It was difficult to actually convince people and convince surgeons not to use because some of them were routinely using it. And secondary objective was also to look at the effect of moxiflox on the corneal endothelium. So in terms of the mean age, gender distribution, the type of cataract, both the groups were well matched. And in terms of logmar visual acuity, there was a difference in visual acuity because of the grade of the cataract that was there. And that is why the preoperative visual acuity was significantly different in the two groups. But then when you're looking for prevention of prophylaxis, I think that really should not make a difference. Rest all of the parameters, the incision size, type, location, IOL optic, IOL haptic were similar for both the groups. So also was the IOL position, IOL type, IOL insertion method, and wound closure, as well as whether posterior capsular rupture was present or not. There were complications, and that sub-analysis we have to do what happens in the cases which are complicated. But overall, when we looked at the visual acuity, the IOP post-operatively, and endothelial cell density, as well as CCT and systemic adverse events, there was no difference between the two groups, which means to say that moxifloxacin is quite safe as far as the endothelial health is concerned, and so is the intraocular pressure and CCT. In terms of the mean intraocular pressure, endothelial cell loss, and central corneal thickness post-operatively also, it was found to be similar in the moxifloxacin group, and as expected, the visual acuity was better. In the control group also, as expected, the visual acuity. What happened? It's flashing here, but
Yeah.
so overall 16,000 cases, 8,000 in each group, and number of cases with endophthalmitis was 38. In the moxifloxacin group, there were 14. In the control group, there were 24. And none of the patients developing endophthalmitis had intraoperative PCR in either of the two groups. So no ocular or systemic adverse events were reported with intracameral moxifloxacin. So if you look at that way, this is perhaps the first randomized control trial which has looked at such a huge number of subjects, and has clearly shown that in those cases where you do give intracameral moxifloxacin, the endophthalmitis rates are much less. Another thing we just looked at was, because this is preliminary analysis, and for this presentation we had to do it, but we are doing a subgroup analysis also to see other intraoperative complications when they are there, like iris prolapse, or like dialysis, etc. What happens in those cases between the two groups? But as far as this study was concerned, none of the groups had PCR who developed, or none of the cases had PCR in either of the groups who developed endophthalmitis. So I think this is a robust data, mainly also because it's from two tertiary eye care centers, and it is a prospective data. So we don't have such a huge sample size prospective study. So possibly when we do a detailed analysis, we would come out with more recommendations and more findings. So thank you very much for your kind attention.
Thank you, Dr. Namrata. So we have to conclude the session, and I thank all the speakers and our chairperson, Dr. Lalit Verma, the current president, speakers, Dr. Avnindra, Dr. Namrata, and Dr. Rajesh for joining us and making this interesting session lively, and also the audience for making it a lively and interactive session. I hope it was useful to all of you. I thank CIPLA for sponsoring and helping us with this session. Thank you.